As usual, it's such a pleasure to be there with all of you. Lovely to see your faces. Uh, when I was asked to speak about my most challenging case, I couldn't think of one, but I just picked about three or four. I'm just going to start my timer. Just 1 second. There you go. So I don't take too much time. So these are a few cases that I thought mattered a lot to me. Some because of the patient, some because of the technicality, and I thought I'd share these with you. A small built 87-year-old man, no diabetes, no hypertension, presented with ACS syncope, melena, GI bleed, hemoglobin dropped to 7.6. He had an in-hospital cardiac arrest, CPR, on ventilator, deteriorating renal function, creatinine shot up to 1.93. You all know once these 80 and 90-year-olds come, how quickly they deteriorate. Extremely narrow valve opening, 0.21 centimeters squared, 103 mean gradient, both surgical and transcatheter turned down, heart function started dropping. Look at that aorta. I have not seen an aortic valve like this in a long time. So there was no valve, there was only calcium. Nasty calcium, heavily calcified valve. You can see just a rock there. And this was early on, this was in February 2017. So terrible case. So went in, did an 18 balloon pre-dilatation, and that's how the valve looked, like a complete noodle. So at this point of time, I put all the coronary practice into effect, recaptured the valve, and that's the beauty of this valve. Recaptured the valve, took it out. So you might ask me, Sai, the position looks good. Why did you recapture it? The problem is that if there's so much of infold, you'll have a nightmare taking the nose cone out. So it's just simpler to recapture the valve, take it out, do a more aggressive pre-dilatation with a 22 balloon, and then deploy the valve. And still the valve looks narrow, but much better than before. But you can see this unyielding rock of calcium here on the LCC side. So mean gradient was 32. I couldn't leave him alone. Just keep looking at that calcium leaflet break. No matter how many times I look at it, I can't help thinking that how blessed I was to get away with something like this. So patient did extremely well, mean gradient 4, hardly any leak. So this was his hospital notes. You can see 107 pre-procedure, 4 post-procedure, 1 year later, still 6. And he traveled alone by himself to Singapore to talk about his second lease of life. So the next patient, 82-year-old man, a medical doctor from 1995 batch of Stanley Medical College, served 33 years in the Indian Army, post-CABG with aortic valve replacement in 2006, severe aortic stenosis due to surgical valve failure, miserable quality of life with repeated episodes of pulmonary edema, severe restriction of activity. He was refused all treatment options, including TAVR, by multiple centers because of nasty femorals, frailty, no carotid subclavian access. And this was a very heart-wrenching email he wrote to me. So I've just blocked out all the other institution names, but he said, I'm not functional and need support from my family members for my daily routine. For an army man who's lived a very regimental life, most of his existence, to come and say that even to use the restroom, I need to use my grandchildren. I don't want to live like this doctor. And you can see why. So look at how it's only 2.1, 4.3, nasty iliacs. And you can see how the dilator is moving the entire aorta. So very gradually ballooned it, and at each stage checking, trying to move it, but stuck again. And this is the trick with dealing with these femorals. The key is to leave a big sheet so you can quickly handle it if there's an issue. And millimeter by millimeter, you go up on the balloon, leave it there, and then try to use a balloon assisted crossing where you put the sheet on the edge of the balloon and move it little by little further up. So still stuck, 1 more millimeter. You can see I'm using the sheet like how you use a balloon assisted crossing in radials, checking the iliac each time. And then finally the sheet is across. You can see the amount of strain it takes to get the sheet across. So once the sheet is across, you can see how beautifully the valve just dances through. That's why this is such a low profile device. Just look at how it goes through. Right through, across the previous valve. We get a perfect implant. And while coming out, everything looks good. I remember my colleague telling me, sir, do you want to fix the other iliac? I said, hey, we are here to do a TAVI, not peripheral angioplasty. Let's get the hell out. So this was Mr. Sundaram, second post-op day back home with his grandchildren. Valve in valve, unforgivable anatomy. So this was a patient referred to me by another operator, a good friend of mine. He implanted the valve It was a very technical implant, and I completely laud him on this implant. You can see it's almost horizontal. But when he put the valve inside the valve, he was only at 6 millimeters. But 2 weeks later, patient came back extremely symptomatic. Gradient was 48. And then when we did the fluoro, we found out the valve had actually milked in. It had milked in because this part of the aorta, when the heart contracted, actually pushed the valve in. So now the valve was almost deep in. We did a CT, and the CT shows how the valve is imprinting on the aorta, and it's almost poking out of the aorta here. So here is a challenge. Now, if I try snaring the valve and pulling out, it might dissect the aorta, and there's no guarantee it will stay in its place. If I put a second valve into this valve, already the small EOA is going to become worse, and the patient is going to be even more miserable. So first did the proper hemodynamics with the Gollan's equation, calculated cardiac output, aortic valve area, everything with the pulmonary cath. After that, decided to take Atlas Gold balloon and fractured the valve frame. Post valve frame fracture, you can see the mean gradient, the peak gradient was almost 50 before and nothing post. Patient did extremely well and went home in 2 days. So this is another case that I really quite like. How am I on time? Okay, good. 7 more minutes. It's not too fast, is it, Dr. Sridhar? I can keep going? Dr. Sridhar, is it too fast or I can keep going?
You can keep going.
Okay. So, so this was a patient, 78-year-old lady, hypertensive, atrial fibrillation, multiple episodes of GI bleed, multiple minor strokes, good neurological recovery, LA closure in 2017, Soren bicarbon prosthetic valve in 2001, 2009 Soren pericarbon freedom 21 valve, severe bioprosthetic AS, mean gradient 57, EF 50, prohibited for surgery. You can see the coronaries are almost 2 to 3 mm, hardly any SOE. And there's no sinus at all, and the coronaries are much lower than the CT. It looks like the coronaries are 1 mm and 3 mm. So 2 guides from both radials, 1 stent in the RCA ostium, 1 stent in the left main ostium. Then under TE, we take the valve in, beautifully release the self-expanding valve. This is a very important stage. You have to finish everything with the valve before your stents. So the post-dilatation was done. After the post-dilatation, left coronary artery chimney. Then RCA chimney. And excellent gradient, hardly any PVL discharged. This is a 6-month follow-up CT, which shows she's completely asymptomatic. You can see the chimney in the left main and the chimney in the RCA stent, fully patent. Patient is doing extremely well till today. Pure AR. So 64-year-old man, severe AR for over 10 years on follow-up with me, gradually worsening, finally planned for TAVR in December. He kept giving me every possible excuse, his children's marriage, had to play with his grandchildren, take his dog for a walk, you name the excuse, I've seen it all. Presented with cardiac arrest to the ER. And this was why, this is one patient who's very dear to me. I've known the family for over 12 years. 10 years he's on follow-up with me. And we plan in December. Luckily, when I'm in hospital, he comes with cardiac arrest to the ER. Hugely dilated LV, severe AR, unable to ventilate, his lungs were too wet. I shifted the patient into the cath lab. Look at that LV. This was the last recorded echo, 3 weeks before he came with an arrest. It's a 9.21 centimeter left ventricle. So you can see in 2018, I planned his TAVR. He was a 29 valve then. And now in 2019, he became a 34 valve. So the LV was dilating aggressively. Even in a period of 1 year, it's gone up. So on cardiac arrest, between cycles, went in, deployed the first valve. And because there was no calcium, what I did was I used the frame of the first valve as anchoring for the second valve to get a good seal. So the trick is you just go in, put one valve in, let it go wherever it wants to go. Then snare that valve and use the first valve as an anchor to actually put your second valve in. So you can see the whole procedure is done during and in between CPR. So you can see the standing still heart, the second valve positioning, and while CPR, I'm releasing the snare. We got a perfect seal. The patient did extremely well. This was day 1. This was day 3. This was day 5 at discharge. And I don't know if you can hear the audio, but he's telling me Happy Diwali from home. So extreme obesity. How many minutes am I? Good. I have another 4 minutes. So 5 foot 2 inches, 137 kilos. Day 1, day 2 at discharge. Extreme frailty, septal bulge, aortic dissection, porcelain aorta, lead pipe aorta, huge abdominal aortic dissection. And we went through all this. 83-year-old, 5 foot 2, 32 kilos, severe AS, syncope, fall, GI bleed, 41 days in CCU, long ventilation. Second post-op day, she was on TPs. She went home in exactly 8 days from the procedure. This was a case that Medtronic IFU actually said that this cannot be done because the dimensions, the minimum diameter was only 5 millimeters. The patient does not appear to meet the recommended for evolutar. Look at that. That was a complete porcelain aorta. We went in. This is exactly 20 minutes after the procedure. 86-year-old, 5 foot 7 inches, 36 kilos, EF 25%, bedridden for over 2 years. So to conclude all that, I would like to say it's never your first mistake that kills your patients. It's usually the one you make after that. Planning ahead and patient selection account for 80% of work to good outcomes. A good understanding of imaging, that is echo, CT, and fluoro, and meticulous attention to detail. Pre, peri, and post procedures, the recipe for reproducible, predictable, and excellent outcomes, irrespective of how tough the case is. Thank you all so much.
Yeah, thank you very much. Really very beautiful and very high risk complex cases. That shows your versatility. Really managing them, very challenging and beautifully handled. And
Thank you so much.
very good complex cases. Very many are almost like contraindications, but you manage it very well, and the outcome is very good.
Yeah, Dr. Chandra said, show me the most memorable cases. So I thought I'll put a few together.
Dr. Raj here. Can you hear me?
Hi, sir. I can see you also. Good morning.
Yeah, fine. Just wanted to know this ER patient you did it.
Yes, sir.
Is it, in ER patient where there is no calcium,
Yes, sir.
it's recommended that you put a valve first and use tanker and put another valve?
Yes, sir. So what happens is, sir, I've done about 4 to 5 ARs. And sometimes what we have the luxury of doing is that we have the luxury of slow. What I like to do is I open the valve about, say, 70%, 30%. Just before annular contact, I rapid pace and cut cardiac output completely. On a almost cut cardiac output, I make annular contact. I then release the cardiac output. Again, I rapid pace cut cardiac output. So I do the entire procedure on a standing still heart, including the release, allowing the patient to breathe in between. Now, if the valve dives in because there's no calcium, then I snare it and use the first valve as an anchor. But in this patient, I had no choice. He was already in cardiac arrest. So I had no time to think. So I just took one valve, put it wherever it went, put the second valve to get a clean seal. And I knew the LV was so big that no matter how deep the valve went, it won't impinge on the mitral. And the sinuses were so huge, I was sure the coronary won't get occluded by the tube graft.
Yeah, very nicely done. Congratulations. Very elegant case. Thank you.
Thank you so much, sir. Dr. Chandra, Dr. Dugal, anything else?
Fantastic cases. Excellent cases.
Thank you so much, Chandra, sir. Sir, you're on mute. I can't hear you.
I'm not on mute.
Now you're back.
Yeah, you seem to have a huge collection of cases. We will ask Dr. Dugal to speak now. And
Sure.
if the other speakers do not join us, we will come back to you. If it is possible, just dish out some cases.
No problem. Happy to show.
Okay. So let me request Dr. Dugal to show us this case.